A very good morning to one and all. Today's session is on gene therapy and genome editing in neurology. Myself, Dr. Anagha, and the moderator today's session is Dr. Sayooja. So there are over 300 million people living with rare neurological disorders worldwide, and they are often a challenge to diagnose. However, in the past decade, there has been major advances in diagnostics, particularly in the field of genome next generation sequencing. And there has also been the advent of newborn screening panel, which enables detection of these neurogenetic disorders at an early pre-symptomatic or early symptomatic. In the field of neurogenetic therapy, the first treatment administered was nusinersen, which was an antisense oligonucleotide, which is approved in 2016 to treat spinal muscular atrophy. After which there has been several groundbreaking research in the field of neurogenetic therapy, and currently there are over 2,000 clinical trials that are ongoing in this field. So before we go into gene therapy proper, we'll just brush up the basics of neurogenetics. So coming to the types of DNA mutations, as we all know, there are different types of DNA mutations, including deletion, insertion, and duplication, and there is inversion within the DNA template, and there can also be translocation mutations within the DNA template. And within a single DNA strand, there can be changes with regard to a single or one couple nucleotide base pairs that can lead to point mutations or frame shift mutations. So when there is a single change in a single nucleotide base pair, that has no effect on the protein sequence. That is, the same amino acid is produced with this change in nucleotide base pair. This is known as a silent mutation. And in a missense mutation, when there is a change in nucleotide base, then there is a difference in the amino acid produced, and hence there will be a difference in the protein that is produced. This is known as missense mutation. And in case of a nonsense mutation, this change in the nucleotide results in a stop codon that results in the protein that is targeted will not be produced when there is a nonsense mutation. In case of a frame shift mutation, due to the addition of this nucleotide base pair, there will be a change in the reading frame. Hence, there will be a change in all the amino acids that is produced sequentially, and the protein produced will also be different. Coming to the mechanism of disease causation, the mechanism is usually different with autosomal dominant or autosomal or X-linked dominant inheritance and recessive inheritance. In case of recessive inheritance, there is usually a reduced expression or a loss of function with preserved expression. And in case of dominant inheritance, there will be a toxic gain of function, dominant negative, or haploinsufficiency. We'll see into each of these in detail. Coming to autosomal recessive inheritance, as we all know, with here there is this black colored label is the wild type allele or the normal allele, and the blue is the mutant allele. So when there are two parents, both of them are carriers of the disease, that there is one mutant allele in each of the parent. If the child receives the wild type allele or the normal allele from both of the parents, they are unaffected. And if they inherit one mutant allele from each of the parent, they are carriers. If they inherit both of the alleles inherited are mutant alleles, then they are affected. So this is the diagram representing the normal gene expression. That is, there are two wild type or normal alleles. With transcription, they produce normal mRNA, and with translation, they produce normal protein. There is 100% normal protein with normal expression. So in case of carriers, that is, there is one wild type allele and one mutant allele. So in this case, this mRNA produced will also be a mutant mRNA. So if this codes for a stop codon, then it forms a nonsense mutation, and then there is nonsense mediated decay. So here only 50% of the protein produced will be normal. That is, only 50% of the protein will be expressed. Another way in which the carrier can manifest is that the mutant allele codes for a different protein that is non-functional. So here there is 100% protein expression, but only 50% is functional. Usually in autosomal recessive disease, carriers will not be manifesting the disease. Whereas in case of when the patient is affected, that is, both the strands carry the mutant allele, there can be two ways in which this can manifest. One is that there is nonsense mediated decay, that is, there is no protein that is produced. Another is the loss of function, as we have seen here. There is a protein that is formed, but that is not functional. So here there is 100% protein expression, but 0% is functional. So here in case of autosomal recessive inheritance, there is either reduced expression or formation of non-functional protein with 100% expression. So the gene therapy that will be required in these disorders will be mainly to replace the protein that is not produced or the protein that is dysfunctional. So examples of this in case of an autosomal recessive inheritance is Pompe's disease. So this is due to recessive mutations in the GAA, which encodes for the alpha-1,4-glucosidase. This alpha-1,4-glucosidase is the lysosomal protein that is involved in glycogen breakdown. So here in this disease, there is reduced expression of the alpha-1,4-glucosidase or production of a protein with impaired function, ultimately resulting in reduced enzyme activity. With case of X-linked inheritance, X-linked recessive inheritance, another example is Duchenne muscular dystrophy. Here, there is a dystrophy resulting from DMD mutation that causing complete loss of the dystrophin production. And in case of Becker's muscular dystrophy, there is reduced production of this dystrophin protein. Haploinsufficiency. It is in autosomal recessive diseases, this does not manifest actually. In autosomal dominant, that is known as haploinsufficiency, and the disease will be manifesting, which will be coming now. So in case of autosomal dominant inheritance, as we know, if the patient inherits, if the child inherits at least one mutant gene from either of the parent, the patient will be affected. So here, there are different ways in which the autosomal dominant inheritance can manifest. So one is haploinsufficiency, as we have seen before. This is the same mechanism as we have seen in a carrier. So here there is either 50% of the only 50% of the normal protein is produced. Or another scenario is that the 50% produced is 50% protein that is produced is non-functional. This is known as haploinsufficiency, where there is reduced protein production resulting in manifestation of the disease. So one example for this is the FSHD type 2. So here FSHD type 2 is due to a mutation in SMCHD1 gene. So this encodes for a methyl transferase enzyme that suppresses the toxic expression of the DUX4 gene. So ultimately resulting in toxic expression of the DUX4 gene, resulting in muscular dystrophy. So another mechanism with which it can act is by the toxic gain of function. So here the mutant allele encodes for a protein that is toxic. So this toxic proteins form aggregated mutant protein, equist proteins, and interferes with the central protein quality control. So one example of this is the myotilleinopathies. So in case of myotilleinopathies, there is mutations in this myotillin protein. So this causes abnormal protein aggregates, that the mutant protein that is forms aggregates known as spheroid bodies. So this spheroid bodies causes sequestration of the normal protein and resulting in myotilleinopathies. Another mechanism by which this toxic gain of function can manifest is that the mutant allele, that is the diseased allele, forms RNA aggregates. So here the RNA aggregates affects the normal mRNA function and the normal protein functioning, and hence there is reduced activity of the normal gene. So one example of this is the myotonic dystrophy. So here there is mutation in the DMPK gene. This forms the DMPK mRNA that interferes with the splicing of the normal mRNA, forming the normal protein, hence resulting in the disease manifestation. So another mechanism by which the autosomal dominant inheritance can manifest is by the dominant negative function. So the dominant negative action occurs in proteins which has to polymerize to function adequately. So here the mutant allele causes a mutant mRNA. So this results in mutant form of the protein. So when this dysfunctional protein polymerizes with the normal protein, this normal protein will also be not fully functional. So here, when the dimeric non-functional protein incorporates with the normal protein, only 25% of the dimers will be functional. So one example of this is the collagen 6 related dystrophies, in which this mutant protein polymerizes with the normal protein and resulting in abnormal protein function. So this is the basic of therapy. So as we have seen here in autosomal recessive disorder, the normal protein is not produced, or there is reduced production of normal protein. So hence the gene therapy will have to be focused on supplementing the normal protein. Whereas in case of autosomal dominant inheritance, there is abnormal protein that is produced. So the gene therapy should be targeted at preventing the formation of this abnormal protein. Except the dominant haploinsufficiency, when there is reduced protein, so it has to be, the protein also will have to be supplemented. So coming to gene therapy, this refers to the therapeutic use of genetic material to treat or prevent disease. So gene therapy changes how proteins are produced or function in the patient's cells. This is targeted either to correct a genetic defect directly or to compensate a disease mechanism. So there are different types of gene therapy. One method of classification is the somatic and germline gene therapy. Somatic gene therapy effects, in somatic gene therapy, the effects are caused by foreign gene that is restricted to the individual patient only. Whereas in case of germline therapy, the functional genes which are inherited, integrated into the genome are inserted in germ cells, that is sperm or eggs. And this targeting of germ cells makes the therapy heritable. The germline gene therapies, none of the germline gene therapies are approved, or currently there are no trials ongoing with germline gene therapy due to ethical issues. So all of the therapies which we are discussing today will be somatic gene therapies alone. Coming to the techniques of gene therapy, there are basically three methods of gene therapy, that is gene augmentation, gene suppression, and genome editing. So first is gene augmentation. So here, like we mentioned before, in case of autosomal recessive, there is loss of function mutation. That is, there is a mutation that results in the protein not being produced, so there is reduced production of protein. So correct. Case of cells with gain of function mutation. So here there are the gene that is transferred is inhibitory sequence, which can be a small interfering RNA or an antisense oligonucleotide. So this suppresses the action of the cell with the gain of function mutation, hence suppressing the production of the toxic protein. Another method is the genome editing. So here there is so what the particle that is transferred is a nuclease along with the DNA template. So this nuclease excises the splices the DNA strand at positions of mutation, and the DNA template further corrects the genetic mutation. So here there is this can be with two methods, that is a homology directed repair or non-homologous end joining. Homology directed repair, the DNA donor pair template introduced into the cell will be used for homologous recombination. So here, basically this nuclease, the nuclease enzyme that we are inserting will induce breaks in the DNA strands at the point of mutation. And the corresponding complementary DNA will be there, that is the normal complementary DNA. And this DNA template that we are inserting will form base pairs with the normal complementary DNA and form normal protein. Whereas in case of non-homologous end joining, either one mechanism is complete knockdown of the protein, that is the nuclease will excise the induced breaks in the DNA strand at point of mutation and will suppress the formation of toxic protein. Another form is by addition, that is the DNA template that we are inserting will join the two ends of broken DNA and form normal protein. So coming to decision tree to select treatment, like we mentioned before, in case of recessive mutation with reduced expression or reduced function, or in case of haploinsufficiency with dominant mutation, the main method of therapy will be gene replacement or supplementation. That is the gene augmentation therapy method which we have discussed. Whereas in case of dominant mutations with toxic gain of function or dominant negative, if the knockout is tolerated, then the knockdown basically means gene suppression. So the gene suppression can be with the whole of the DNA strand as such, which is known as, which here is termed as knockdown, or it can be allele specific, that is a single allele is suppressed, that is known as allele specific knockdown. So in case of toxic gain of function or dominant negative mutation, this knockdown, that is gene suppression along with gene replacement, will be needed. Coming to the methods of gene transfer, there are basically two methods. One is ex vivo gene therapy, where there is transfer of genes into patient cell outside the body. And there is in vivo gene therapy, where there is transfer of genes directly to the cells inside the body. So in case of ex vivo gene therapy, the cells are harvested containing the the cells that are with defective genes are harvested from the patient, and these are grown in cultures outside the body. And then the recombinant DNA or RNA is inserted into these cells. Then these cells are cultured ex vivo, and then they are reinfused into the patient. So this is the ex vivo gene therapy. Whereas in case of in vivo gene therapy, the genetically altered DNA is inserted into the patient's body by direct injection. So here the inserted DNA or RNA is incorporated into the specific cell and produces the needed protein encoded by the inserted gene. So coming to the mechanisms of gene therapy, there are basically four mechanisms. That is the antisense oligonucleotide, small molecule, small interfering RNA, and the gene replacement therapy. First, antisense oligonucleotide. These are short, single-stranded chemically modified oligonucleotide molecules that bind to the messenger RNA and alter the RNA structure or function. So basically, there can be two mechanisms with which this antisense oligonucleotide can function. So one is that this ASO binds to the mRNA and it induces the RNase H. So this RNase H enzyme cleaves the dysfunctional mRNA, resulting in degradation of the target mRNA. Hence, inhibiting the mRNA from acting and producing a toxic protein. Another method is by targeting the exon of interest. So with this, there can be either exon skipping or exon inclusion. So in case of exon skipping and exon inclusion, this antisense oligonucleotide binds to the target mRNA and decides whether this exon should be included in the protein production or not. So in either of these methods, there is expression of an isoform of the targeted protein. So this protein may not have this isoform of the targeted protein may not have all the functions of the normal protein there, but they will still have some partial functions of the protein and will be able to compensate for the disease activity. So this method is used in case of both antisense oligonucleotide and with small molecules. The examples of antisense oligonucleotides that are currently approved include nusinersen for spinal muscular atrophy, tofersen for SOD1 related ALS, and exon skipping therapies for Duchenne muscular dystrophy. And one specialty with antisense oligonucleotide is that the currently available ASOs do not cross the blood-brain barrier. Hence, all of the application must be intrathecal. The strategies to overcome this hurdle include coupling to specific conjugate substances like galactyl N-acetate or enveloping the ASO in a vector, like in case of a lipid nanoparticle. The disadvantage is that they have limited half-life and need to be administered on a regular basis, and this will require repeated lumbar punctures. However, the advantage is that the application is CNS specific, and if there is any severe adverse effect, the treatment can be stopped then and there. The next method of gene therapy is by use of small molecules. Like we have seen before, the RNA splice, this is mainly having the same action as antisense oligonucleotide. So these small molecules acts at the exon and decide whether the exon should be skipped or should be included in gene expression. So compared to ASOs, they exhibit a comparatively good biodistribution and tissue penetrance. An example of small molecule is the use of risdiplam in treatment of spinal muscular atrophy. Another method of gene therapy is small interfering RNAs. This consists of 20 to 25 base pair short RNA double strand complementary to the target mRNA. So this small interfering RNA, once they bind to the mRNA, they lead to the formation of RNA-induced silencing complex. So this RNA-induced silencing complexes result in degradation of complementary RNA after its binding to this complex and results in degradation of the target mRNA. And hence by inhibiting the expression of this mutant gene. The disadvantage is that they have limited bioavailability and requires a vector for transmission. Examples include patisiran and vutrisiran, which is used for hereditary transthyretin-mediated amyloidosis. The next method of gene therapy is gene replacement therapy. Here, the synthetic DNA that is transcribed by reverse transcriptase from mRNA encoding the deficient protein is transmitted via a viral vector. So the viral vector used is either non-replicating, natural, or engineered, the adeno-associated virus capsid. And in case of these gene replacement therapy, the promoter part, that is the nucleotide base pair that is preceding the actual gene that is encoding the protein. This decides if the exogenous gene is injection will be single administration will be enough for this therapy. The advantage is that the treatment cannot be terminated and unwanted effects may persist. So as we have mentioned, gene replacement therapy uses vector-based vectors for transmission of the gene into the cells. So this vector-based gene therapy can function with gene replacement or gene silencing. So here in gene replacement, the transferred gene encodes a functional protein that compensates for the loss of function. In case of gene silencing, the regulatory mRNA downregulate the expression of target mRNA by RNA interference in order to counteract the gain of function mutation. So the vectors used in gene therapy, there are viral vectors and non-viral vectors used. Among viral vectors, adenovirus and lentivirus are the most commonly used viral vectors. In case of non-viral vectors, the lipid complex, liposomes, peptide or protein and polymers are used. And apart from this, there are also methods of direct gene transfers, like transfer methods like mechanical electroporation or gene gun that are used to transfer genes into the target cells. So the most commonly used vector is the viral vectors, among which adeno-associated viral gene therapy and the lentivirus gene therapy are the most commonly used ones. So to compare between these two viral vectors, in case of adeno-associated virus gene therapy, the genome in this virus is a single-stranded or double-stranded DNA, whereas in case of lentivirus, it's a single-stranded RNA. And the nature of virion, so the entire virus is not transmitted to the cell, only the protein capsid of the virus is transmitted that envelops the recombinant DNA or RNA that we are administering to the patient. In case of adeno-associated virus, it is the protein capsid, whereas in case of lentivirus, it is an envelope protein. The limit of deliverable genetic payload sizes is more for lentivirus gene therapy, which is around 7.5 kb, whereas in case of adeno-associated virus, it is 4.8 kb. And the fate of viral genome after transduction, in case of adeno-associated virus, this DNA which we are administering do not integrate into the genome unless the free DNA ends are present due to breakage or via targeted nuclease activity. Whereas in case of lentivirus gene therapy, this lentivirus resembles HIV virus in its function. So this virus, so the DNA which we are administering to lentivirus gene therapy naturally integrate into the genome with the help of viral nucleases. Coming to routes of drug delivery into the CNS, there are several routes. So as we have seen before, most of these do not cross the blood-brain barrier and direct injection to the CNS or peripheral nervous system will be required. So the methods of injection include intracerebroventricular, intraparenchymal, intracisternal magna, and intrathecal. And there are also intravenous routes of administration. Coming to the gene therapies for neurological disease. So these are the currently FDA approved gene therapies. These are the diseases for which there is currently approval by the US FDA or the European medical agencies. This includes spinal muscular atrophy, metachromatic leukodystrophy, cerebral adrenoleukodystrophy, aromatic L-amino acid decarboxylase deficiency, Duchenne muscular dystrophy, amyotrophic lateral sclerosis, and hereditary transthyretin-mediated amyloidosis. So we'll look into each of this in detail. So first is spinal muscular atrophy. This is an autosomal recessive disorder that is resulting from mutation in SMN1 gene that encodes the survival motor neuron protein. So this results in the loss of anterior horn cells in spinal cord, resulting in progressive LMN weakness. So here, as we have seen in SMN1 gene, there is defective production of the survival motor neuron protein, resulting in muscle atrophy. However, there is an SMN2 gene, and the action of this SMN2 gene is what decides the severity of the spinal muscular atrophy. So this in normal individuals in SMN2 gene, this exon 7 undergoes splicing, resulting in 80% of the proteins produced are truncated or degraded, and only 20% of the proteins are functional in this SMN2 gene. So the more the number of SMN2 copies, the lesser will be the disease severity in case of SMA. So in case of SMA type 1, there will be very less number of SMN2 copies, whereas in case of SMA 2 or 3, there will be progressive increase in the number of SMN2 copies, resulting in better protein production. So the approved therapies for SMA include, there are currently mainly 3 approved therapies. First is nusinersen. This was approved in 2016. Nusinersen is an antisense oligonucleotide that is complementary to a regulatory element upstream of exon 7 and SMN2. And this leads to inclusion during alternative splicing and producing a stable mRNA product. So the administration of the nusinersen, as we have seen in case of antisense oligonucleotide, they have poor, they do not cross the blood-brain barrier. So hence intrathecal administration has to be done. The course of administration, first 3 loading doses have to be done every 14 days. And the 4th dose is given 30 days after the 3rd dose. And further maintenance doses will have to be given every 4 months. Apart from this, the next gene therapy approved is the onasemnogene abipavovec. This was approved in May 2019. This is an adeno-associated virus 9 vector-based therapy containing full-length functional copy of SMN gene. And as we have seen with the case of vector-based DNA replacement therapy, a single IV dose will be enough. So a single weight-based IV dose is used in these patients. And the next therapy that is approved is a small molecule therapy, that is risdiplam, which was approved in August 2020. As we have seen, this small molecule acts by increasing the splicing efficacy. And this is administered as daily oral medications. So there has been several trials that has been done basically on nusinersen and onasemnogene abipavovec. With nusinersen, the CHERISH trial and the NURTURE trial have shown that administration of nusinersen has resulted in better functional outcomes. So that is, the ability to sit at 5 years was obtained for nusinersen and onasemnogene abipavovec compared to the control cases. Coming to treatment consideration with nusinersen, the safety risks are mainly with the complications of intrathecal administration. And apart from that, there is also side effects with thrombocytopenia, coagulation abnormalities, and renal toxicities. And patients on nusinersen have to be monitored with CBC, coagulation parameters, and urine protein. Onasemnogene abipavovec is an adeno-associated virus gene therapy, and adeno-associated virus antibody titers will have to be monitored. And in this, due to an immunogenicity to the viral capsid, there can be immune-mediated hepatitis that results in hepatotoxicity. So for the first 1 month, from 24 hours to 1 month after the course of the therapy, the patient will have to be on oral steroids. Other side effects mentioned are thrombocytopenia, thrombotic microangiopathy, and cardiac events. The next disease with which, for which FDA has approved gene therapy is X-linked adrenoleukodystrophy. This is a paroxysmal disorder that is caused by deficient beta oxidation of very long-chain fatty acids secondary to pathogenic variants in ABCD1 gene. So there are basically 2 primary neurologic phenotypes. First is the cerebral adrenoleukodystrophy. This results in a rapidly progressive childhood onset severe demyelination with early behavioral changes and progressive loss of communication, spastic quadriparesis, blindness, deafness, and ultimately death within 2 to 5 years of onset. Another neurologic phenotype is adrenomyeloneuropathy, which has a more insidious course with progressive spastic quadriparesis, neurogenic bladder, and sexual dysfunction. And in 80% of these patients, there is adrenal insufficiency. The diagnosis is by identification of pathogenic variants in ABCD1 gene and by detection of elevated fasting very long-chain fatty acid levels. Allogenic hematopoietic stem cell transplant is currently the standard of care in these patients. And the MRI finding in this patient is 3-2 flare hyperintensities with contrast enhancement that begin from the splenium of corpus callosum that extends to the parieto-occipital lobes bilaterally. And there is a scoring method that is the Lowe's MRI score. This is specifically important in case of genetic therapy because this defines the thresholds for treatment eligibility in this patient. And the total score is 34, and each of these points carry 1 score each. That is the presence of hyperintensities involving each of these parts carry 1 point each. And the gene therapy that is approved for this is the elivaldogene autotemcel or the ELI cell. This is a lentiviral-based ex vivo autologous stem cell therapy. And this has been approved in patients aged 4 to 17 years with early symptomatic cerebral adrenoleukodystrophy. And the eligibility criteria particularly is asymptomatic or mildly symptomatic patients, that is with a neurologic function score of less than 1, with gadolinium enhancement on MRI brain, and the lowest score which we have seen between 0.5 to 9. And the method of administration, so here the patient is initially administered granulocyte colony stimulating factors, after which the CD34 plus cells are obtained from the patients by apheresis. And ex vivo, this CD34 plus cells are administered this lentiviral vector carrying the gene therapy. And this is administered to the patient after conditioning the patient with busulfan or cyclophosphamide. So the trial that is looked at the efficacy of this therapy. So this was published in NEJM in 2024. So in this trial, 32 patients received the ELICell therapy, and at 2 years, none had major functional disabilities, and overall survival was around 94%. And at a long-term follow-up of this patient at 6 years, the neurological function score was stable in around 94% of the patient, and only 81% of the patients had no major functional disabilities. However, there was MDS with excess blast developed in one patient at month 92. Further treatment considerations, this was approved by the FDA in 2021. However, cost effectiveness studies compared to the current standard of therapy, that is with allogenic hematopoietic stem cell transplant, showed that there was no additional cost effectiveness of this gene therapy compared to allogenic hematopoietic stem cell transplant. Hence, this therapy can be used in patients without a suitable stem cell donor. And pre-treatment evaluation of baseline risk of hematological malignancy has to be done in this patient. And post-marketing studies of this therapy after this trial that I've shown, that have again reported multiple other events of hematological malignancies. That is, around 7 more patients have developed hematological malignancy after receival of this therapy. And monitoring for this patient early post-treatment period, patient should be monitored for severe infections, prolonged cytopenias, delayed platelet and failed neutrophil engraftment, mucositis, and GI symptoms. And they have to be monitored. Continuous monitoring will have to be done with CBC every 6 months for at least 15 years. And dedicated clonal expansion testing to look for the efficacy of this therapy will have to be done at least twice yearly in the first year, then and annually thereafter. The next disease for which gene therapy is approved is metachromatic leukodystrophy. This is a rare demyelinating lysosomal storage disorder due to deficient aryl sulfatase A enzyme activity. And it is due to an autosomal recessive mutation in ARSA gene. The subtypes of MLD are defined based on the age of onset. The late infantile is less than 2.5 years, early juvenile MLD between 2.5 to 6 years, late juvenile MLD between 7 to 16 years, and adult onset MLD more than 16 years. And the diagnosis by low ARSA activity and elevated sulfite levels in urine, and by genetic conformation. And currently, there is no approved standard therapy like we have seen in case of adrenoleukodystrophy. And the outcome with hematopoietic stem cell therapy is less well-defined than adrenoleukodystrophy, especially in late juvenile and adult forms. And the gene therapy that is approved is the ATID-ARSA gene autotem cell, or the ARSA cell. So this is a lentivirus-based ex vivo autologous stem cell therapy. The method of administration is same as that we have seen with the adrenoleukodystrophy. This therapy was FDA approved in March 2024, and this is approved for pre-symptomatic late infantile or early juvenile, or early symptomatic early juvenile MLD. And the benefit was limited to patients who was independent for ambulation and without any evidence of cognitive dysfunction at the time of treatment. Coming to the trial that is looked at this ARSA cell therapy for MLD. So in this trial, this was published in April 2025 in NEJM. 39 treated patients and 49 untreated patients were included, with a median follow-up of 6 years. And at 6 years, there was a significantly lower risk of severe motor impairment or death compared to no treatment group. That is, the risk of severe motor impairment and death was 0% in treatment group compared to 100% in the late infantile group. And there was no evidence of insertional oncogenesis, unlike the ALD therapy that we have seen. And the adverse event that was reported was febrile neutropenia. And in 6 of 39 patients, the anti-ARSA antibodies were also detected. So pre-treatment, patients will have to be screened for viruses, and the early post-treatment monitoring is same as that for the ALD therapy. And for the first 1 month, the patient will have to undergo serial LFT and prophylactic anticoagulation due to risk of veno-occlusive disease and thrombotic microangiopathy. That is an immune response to the viral envelope protein. And further, the patient will have to be monitored with annual CBC with differential for 15 years and lifelong based on the clinical symptoms. The next disease for which genetic therapies is early stages. The next disease is the aromatic amino acid decarboxylase deficiency. This is an autosomal recessive disorder. Here there is mutations of the DOPA decarboxylase gene resulting in reduced AADC enzyme level, leading to reduction in dopamine and serotonin, ultimately resulting in reduced synthesis of catecholamines. The patients manifest with developmental delay, dystonia, hypokinesia, characteristic oculogyric crises, irritability, and insomnia. The diagnosis is mainly by detection of biallelic pathogenic mutations in the DDC gene, or other modalities used as CSF or plasma neurotransmitter profile and reduced AADC enzyme activity in plasma. There is a risk of high risk of mortality before 10 years, and the standard treatment currently is with levodopa dopamine agonists and MAO-B inhibitors. The gene therapy approved for this is elidocagene exuparovec. This is an adeno-associated viral vector-based gene therapy containing the complementary DNA of the DDC gene. And this is currently authorized by the European Medical Authority for treatment of patients more than 18 months with clinical, molecular, and genetically confirmed diagnosis of AADC deficiency and with a severe phenotype. And this is administered as biputaminal intracerebral infusions. The trial looking at the efficacy of this therapy was published in 2021. This looked at 26 patients without control group receiving bilateral intraputaminal infusions. And there was rapid improvements in motor and cognitive function that occurred within 12 months and which was sustained during follow-up for more than 5 years. And there was also increase in dopamine demonstrated with PET-CT and neurotransmitter analysis. And there was also improvement in patient symptoms, patient growth, and caretaker quality of life. The procedural complications include CSF leak and dyskinesias associated with the procedure of putaminal infusion. The potential risks include tumorogenicity, immunogenicity, and third-party transmission. The long-term follow-up, there was improvement in oculogyric crisis and ability to sit unassisted, growth, and caregiver quality of life. The next disease for which genetic therapy was approved as the Duchenne muscular dystrophy. This is an X-linked genetic recessive genetic disorder resulting in absence of dystrophin protein. So this leads to destabilization of the sarcolemmal membrane, resulting in muscle necrosis and atrophy with progressive skeletal and cardiac muscle weakness. So here the CPK will be more than 10 times the upper limit of normal, and diagnosis is by genetic study. There are 2 types of therapies approved for Duchenne muscular dystrophy. First is the exon skipping therapies. So here the process is by skipping the problematic exon regions produced by the out-of-frame deletions and rejoining the functional exon segments, resulting in generation of smaller or less functional forms of dystrophin protein. So there are mainly 4 exon skipping therapies that are currently approved by the FDA. So first is the 80% that which was published. The main trial was published in 2016 and approved for use in 2016. This is targeting the exon 51. So the trial that studied around 12 patients and resulted in increased dystrophin positive fibers and a slower decline in 6-minute walking test versus historical controls. However, there was only smaller sample size with modest effect. The next exon skipping therapy approved was the golodirsen in 2020. The study was done with 25 patients with increase in dystrophin levels and trend toward slower 6-minute walking test decline. And it was well tolerated with patients. The other exon skipping therapies was with Viltolarsen, which was approved in 2020, and Casimersen, which was approved in 2023. All of this showed increase in the dystrophin protein levels and the improved functional score versus historical controls and favorable safety profiles. The next therapy that was used with DMD is the delandistrogene moxeparvovec. This is again an adeno-associated virus-based IV gene therapy containing microdystrophin transgene. This was approved for ambulatory and non-ambulatory patients more than 4 years. And the trials have demonstrated functional improvements that were greater when compared to use of corticosteroid alone. This is the result of the EMBARK trial, which was published in October 2024 in Nature. So here, patients between the age of 4 to 8 years who are ambulatory were randomized to single administration of IV deladystrogen moxeparvovec or compared to placebo. And at week 52, the primary endpoint, that is the change from the baseline functional score, was not met. However, there was improvement in the microdystrophin expression at week 12. And other secondary efficacy endpoints in functional scale showed improvement, although this was not statistically significant. Coming to treatment considerations with DMD, the exon skipping therapies were administered weekly and was well tolerated. With eteplirsen, there was some side effect with headache and injection site reaction and proteinuria that was mentioned. Other adverse effects include nausea, vomiting, and elevated GGT. And in patients with 8 to 21 exon deletion, there was increased cytotoxic T cell response to the microdystrophin that was produced, resulting in myositis and carditis, and resulting in severe and abrupt onset of muscle weakness that was described in some patients. Another disease in which genetic therapy is approved is amyotrophic lateral sclerosis. It is a progressive degeneration of UMN and LMN neurons, resulting in progressive paralysis, respiratory failure, and death. The most frequent gene identified is the superoxide dismutase gene, or the SOD1 gene. And with SOD1 gene, there is a toxic gain-of-function mutation causing subsequent accumulation of misfolded protein. And that medicine that is tried in SOD1 positive ALS is tofersen. And the trial, this was published in 2022 in NEJM. So this was an international phase 3 double-blind randomized placebo-controlled trial. And in adults with weakness attributable to ALS and confirmed SOD1 mutation. So in this, there was no significant difference in clinical outcome with this therapy. However, there was reduced concentration of SOD1 and neurofilament light chain levels in plasma over 28 weeks. And the treatment consideration, there were serious adverse effects reported, which include myelitis, radiculitis, papilledema with elevated intracranial pressure and aseptic meningitis, and some other minor adverse effects, including pain, fatigue, arthralgia, myalgia, and CSF pleocytosis. And no data are available for pediatric patients and for pregnant patient and lactating women. For this tofersen trial for SOD1, there was no baseline functional scale that they've looked at. They have only looked at the rate of decline in the functional scale of this MLD patient pre-treatment. So there is no cutoff for the functional score of the patient that can receive this therapy. Another neurological disease for which genetic therapy is approved is the hereditary transthyretin-mediated amyloidosis. In this, for the familial amyloidotic polyneuropathy that presents with progressive sensory motor peripheral polyneuropathy and autonomic neuropathy, genetic study has been tried. And the approved genetic therapies, patisiran and vutrisiran, which are small interfering RNA-based therapies, and eplontersen, that is an ASO therapy that is approved in United States. And all these therapies are for the treatment of polyneuropathy that is due to hereditary transthyretin-mediated amyloidosis. So these are the approved genetic therapies for neurological diseases till now. So, however, there are several other modalities of gene therapy that is currently under trials that will soon come up in a big way in treatment of neurogenetic disorders. So one of which is tRNA regulation. This is the translational RNA. So after the DNA transcribes into mRNA, for the formation of the protein, this tRNA is required. So here, the main therapy is with suppressor tRNA that correct the premature termination codons and nonsense mutation. The advantage is that it offers versatility, that is a single therapy could treat multiple diseases. And this is ideal for Goldilocks genes like in MECP2. Goldilocks gene refers to diseases in which an excess protein and the reduced protein will result in disease manifestation. So here the suppressor tRNA can target only in naturally transcribed mRNAs and prevent the overexpression to maintain the physiological levels of gene expression. And this can be tried in Rett syndrome. However, these are only in preclinical stages currently. Another modality of genetic therapy that is coming up is regulatory element engineering. So here this does not act on the gene, but acts on the promoter that decides the transcription of the gene. So this can be used in disorders caused by the gene dosage. That is in case of haploinsufficiency or gene duplication. This therapy is known as cis regulation therapy and uses the gene's regulatory machinery to rescue and avoid ectopic expression. In patients with haploinsufficiency, there is activation of the promoter gene causing increased gene production, and with duplication, there is silencing of the promoter gene causing reduced gene expression. And the advantage is that it can fit into large single adeno-associated virus, which otherwise cannot accommodate this large genes. And it provides tissue or cell type specificity. And it is a one and done approach, potentially requiring only a single lifetime therapy. Another method of genome therapy, which is coming in a big way, is genome editing therapy, which is mainly by the CRISPR systems. CRISPR refers to clustered, regularly interspersed palindromic repeats. So here, like I've shown in the diagram for genome editing, they employ an RNA-guided nuclease to induce the targeted double-strand breaks. Cas9 refers to CRISPR-associated protein 9. So here there is introduction of a nuclease enzyme that induce targeted double-stranded breaks. And there is associated introduction of a complementary DNA that will act for the deficient mutation. And along with acting on the genome, that is genome editing, there is also epigenome editing. Epigenome refers to all the chemical modifications to the DNA and histone proteins that regulate the gene activity without changing the actual DNA sequence. So this includes all the processes that occur after the transcription to mRNA, that is mainly involving the translation of the mRNA. And this epigenome editing can be used as a potential to be used in these disorders, including X-linked disorders like Rett syndrome, which can, where it can function with reactivation of the healthy X chromosome allele that can restore the normal function. And it can also be used in nucleotide repeat expansion disorders like Huntington's or Fragile X, where there can be reactivation or suppression of silent genes that can rescue the transcriptional defects. And it can also be used in imprinting disorders. So there are currently several trials that are ongoing with these gene therapies. These are mainly 3 trials which have like high visibility and have a high potential in changing the disease course. One is the GDNF gene therapy in Parkinson's disease. So here, this is an adeno-associated viral-based therapy with the injection of this glial cell-derived neurotropic factor, that is the GDNF gene. So there is the application of this adeno-associated virus with the GDNF gene that is injected intraputamen, injected into the putamen. So from whatever reports available till now, it is well tolerated with no serious treatment-related adverse effects. And this is expected to complete by this year. 11 patients have currently been recruited, and as per the news reports, mild cohort showed stability and moderate cohort showed motor improvement in Parkinson's disease. Another disease for which gene therapy has been used is the Dravet syndrome, which is again an adeno-associated virus-based therapy with introduction of SCN1A. And the study is expected to be completed by 2027. And from whatever reports available, there is good tolerability with no serious adverse effects and improvement in seizure frequency. Another therapy that has come up in Huntington's disease is an miRNA-based HTT silencing gene therapy, that is Huntington gene silencing therapy, that is expected to be completed in 2029. And the interim results show safety and potential target engagement with no severe safety issues or dose escalation. And currently dose escalation is ongoing in this therapy. So to conclude, first, when we identify a disease with potential genetic management, we have to look at whether it is monogenic or polygenic, whether there is a gain or loss of function mutation, and whether there is deficiency in the gene expression or an excess. And currently, gene therapy is at the stage of trial recruitment alone. So most of the ethical considerations and regulatory considerations for trial approval will have to be taken. And then what therapy has to be used, this again, as mentioned, depends on the type of disease, whether autosomal dominant or recessive, whether it is a gain of function or loss of function mutation. And accordingly, the therapy that is to be used has to be decided.
For example, you have mentioned Parkinson's disease, which is monogenic field. Rest of them are neurodevelopment, polygenic and interplay of environmental as well as genetic. So what are the challenges in
So the first hurdle is that the patients usually present when the patient starts to have clinical manifestation, there is already certain extent of neurodegeneration that is set in. So intervention at that point may not be clinically beneficial for the patient. Patient will have to be identified at a pre-symptomatic stage for better efficacy of the treatment. With regard to our setting of a developing country, financial consideration and follow-up of the patient will be difficult. And the administration of these gene therapies, most of them, like the Parkinson's disease, the current adeno-associated virus-based therapies, intraputaminal infusions, which again needs a lot of technical expertise.
Find out what is the type of gene therapy. The basic outline is that in case of a recessive loss of function mutation, there is a reduced production of the protein. As well as in dominant haploinsufficiency, there is 50% reduction of the whatever protein is expected, or the protein is not functional. So in both these cases, you have a reduction in the amount of protein produced, and you need to supplement with the gene therapy. That is the gene replacement therapy. That is supplementation therapy. In case of other type of disease, that is a toxic gain of function mutation or a dominant negative condition like in collagenopathies, there is excess production of unwanted protein. So in that case, you have to find out some kind of a knockdown therapy or a gene suppression therapy. That is a basic principle, and various types of gene therapy modalities she has elaborated in detail. And most of the things we have seen that these are monogenic diseases which are coming in a big way. They're every year they're making a lot of molecules. So what is the main challenge in case of a neurodegenerative disorder? That is a question asked. So here, the main thing is that a disease model has to be produced. For example, in Parkinson's disease, we are creating a MPTP model that is not exactly simulating the one which you see in a normal Parkinson's disease, which is actually a much more elaborate and widespread neurodegeneration happening. So it is not exactly, you are never able to create a proper disease model to simulate a original Parkinson's disease. So whatever gene therapy you're trying, it is all on a disease model which you presume that it is like a Parkinson's disease. And you know that Parkinson's disease is a congregation of lot of motor, non-motor symptom and much more widespread neurodegeneration than in the basal ganglia circuits. So that is a big challenge in doing drug trials in this kind of neurodegeneration. But still, this GDNF trials and errors ongoing, and they found that there is some in the functional MRI also, there was some increase in the uptake seen. So that is a hopeful therapy. Thank you.
We are concluding today's session. Thank you.